So hello and welcome to our webinar. My name is Lamont Scales. The title of today's webinar is the CDC's COVID-19 Response, Promising Practices in Health Equity. Today's webinar will focus on key activities that jurisdictions have taken to reduce COVID-19 disparities among racial and ethnic minority groups within the United States. We would like to thank everyone for joining today's webinar. We'd also like to have a special thank you to the National Association of County and City Health Officials for helping to coordinate today's webinar. We would not be able to do this without your help. Next slide, please. The webinar will be recorded today and later posted on CDC's COVID-19 website. So please look back there in a week or two so you can see the recording. As an FYI, everyone is muted except our speakers. The webinar is not intended for the media. Media can direct their questions to media@cdc.gov. If you do have questions at any time, please use the chat function or the Q&A function, and we will address any questions after each of the speakers have had a chance to present their topics. Again, you're muted. If you have questions, use the chat function. Next slide, please. I'm so pleased to be joined today by Dr. Leandris Liebert. Dr. Liebert is the Associate Director for the Office of Minority Health and Health Equity at the CDC. In her role, she leads a wide range of critical functions in the agency's work in minority health and health equity, women's health, and diversity and inclusion management. She plays a critical leadership role in determining the agency's vision for health equity, ensuring rigorous evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in vulnerable communities. Recently, Dr. Liebert has been appointed to the CDC's COVID-19 response as the first Chief Health Equity Officer to expand the health equity approaches within the COVID-19 response. I'll turn it over to Dr. Liebert now.
Thank you, Lamont, and greetings to everyone who has joined us for this important and timely webinar. I've been privileged to spend my entire public health career in the struggle to reduce largely preventable health disparities and pursue health equity. In the 9 years I've served as Associate Director for CDC's Office of Minority Health and Health Equity, I've lent my voice and expertise to addressing a range of health issues and to shining a light on those social factors that help construct patterns of health disparities. The population health impact of COVID-19 has exposed in plain sight decades, if not centuries, of inequities that have systematically undermined the physical, social, material, and emotional health of racial and ethnic minority populations and other groups. The past few weeks have draped anger on top of the fear and dread COVID-19 already caused in the African American community. And as we have been working 24/7 to respond to the pandemic, over the past few weeks, our nation has been gripped by the killings of people of color. I would be remiss if I did not acknowledge that we come together this afternoon reeling from all that is going on across this nation and in our own communities. These are difficult days. It is important in these times that we strive for healthy ways to deal with trauma, loss, injustice, and feelings of grief. I thank each of you for the work you do every day to make a difference in the lives of people everywhere, and believe you will leave this webinar with new ideas and some restored hope for how we can accelerate our efforts to achieve health equity. In my role as the first Chief Health Equity Officer for the COVID-19 response, I have been pleased to help chart the path forward for CDC's COVID-19 health equity strategy based on principles to reduce health disparities, to ensure that useful data is available, to meaningfully engage community institutions in planning and implementation of critical work, to implement outreach that is culturally responsive and tailored to address the unique circumstances of groups at high risk of COVID-19, and to reduce stigma, including stigma associated with race and ethnicity. The effects of COVID-19 on the health of racial and ethnic minority groups is still emerging. However, current data suggests a disproportionate burden of illness and death among racial and ethnic minority groups. Non-Hispanic Black and non-Hispanic American Indian, Alaska Native populations have a rate approximately 4.5 times that of non-Hispanic whites, while Hispanic Latinos have a rate approximately 3.5 times that of non-Hispanic whites. Among the 23,811 laboratory-confirmed COVID-19 associated hospitalized cases, 19,775, or 83%, had information available on race and ethnicity, while collection of race and ethnicity data was still pending for 4,036 cases, or 17%. Of the 19,775 cases with race and ethnicity data, 35.6% were non-Hispanic white, 34.1% were non-Hispanic Black, 17.9% were Hispanic Latino, 4.5% were non-Hispanic Asian Pacific Islander, 1.4% were non-Hispanic American Indian or Alaska Native, and 0.2% were multiple race, and 6.3% had unknown race. Persistent health disparities combined with housing patterns, work circumstances, and other factors have put members of many racial and ethnic minority populations at highest risk for COVID-19. History shows that severe illness and death rates tend to be higher for some racial and ethnic minority groups during public health emergencies. Addressing the needs of disproportionately impacted populations in emergencies includes improving day-to-day life and harnessing the strengths of these groups. This means addressing the social determinants of health, such as access to quality health care, housing status, employment, and income needs, while working collaboratively with racial and ethnic minorities. All of these are the key to our success. CDC recognizes that responding to the needs of all communities is a priority in this response, and we strive to continuously identify needs and improve our outreach. As we move forward in the months to come, we will strive to expand the evidence base to increase our understanding of the impact and the factors that lead to the disproportionate burden of COVID-19, to expand testing, contact tracing, isolation options, and care, reaching populations that have been put at increased risk, to expand intervention activities to support essential and frontline workers to prevent transmission of COVID-19, and increasing an inclusive workforce equipped to address and assess the unique needs of an increasingly diverse population. I don't want to take any more time away from our amazing speakers, so I'll stop here and emphasize that CDC is aggressively responding to the global outbreak of COVID-19. So I'd like to introduce our speakers. Our first speaker is Dr. Nafissa Egbuonye. Dr. Egbuonye is the Public Health Director for Black Hawk County Health Department. She earned her doctoral degree in public health education from Texas A&M University and her master's in Public Health from San Diego State University. Dr. Egbuonye has worked with different organizations conducting research, implementing health promotion programs, and advocating for vulnerable populations. Furthermore, she comes from a diverse background and is fluent in 4 major languages. She is accustomed to various cultures, which is necessary when developing public health programs nationally and globally. Our second speaker is Mr. Benicio Gonzales. Serves the residents of Louisville as director for the Center for Health Equity. Began working at the Center for Health Equity in 2010 to coordinate the department's Racial Healing and Equity Initiative. Supports the department's strategy to deepen its focus on the root causes of health through authentic community engagement, strategic partnerships, addressing data gaps and challenges, and through policy analysis and development. As an active community member, is committed to numerous organizations, projects, boards, and community campaigns. Our third speaker will be Dr. Jarvis Chen. Dr. Chen is a social epidemiologist whose research focuses on social inequalities in health, and especially racial, ethnic, and socioeconomic disparities in cancer outcomes. As a methodologist, Dr. Chen's interests include the development of methods for geospatial and spatiotemporal analysis, disease mapping, handling missing data, and latent variable analysis. Our final speaker will be Dr. Thomas LaViest. Dr. LaViest is Dean of the Tulane University School of Public Health and Tropical Medicine. He has written over 150 scientific articles, been featured in numerous mass media outlets, authored 6 books, and is executive producer of The Skin You're In, a documentary series about racial inequalities in health. An award-winning research scientist, Dr. LaViest has received the Innovation Award from the National Institutes of Health, the Knowledge Award from the U.S. Department of Health and Human Services, and was elected to the National Academy of Medicine. After the final presenter, we will open the floor for questions. You can type your questions directly into the chat box. We will only respond to questions posted in the chat box. At this time, I'll turn it over to our first presenter, Dr. Egbuonye. Dr. Egbuonye.
Good afternoon, thank you. And next slide so I can start. I want to start off by thanking Dr. Liebert, CDC staff, and NACHO for putting this panel together and giving the Black Hawk County Health Department an opportunity to highlight our work. So thank you very much. Next slide. So Black Hawk County is located in the northeastern part of Iowa, and I say this because we tend to be confused a lot with Ohio, but we are in Iowa, and it's the northeastern part of Iowa. The population is approximately 131,228 people. It is considered to be the 4th most populous county in Iowa. And the county is a mix of an urban and rural population. The racial makeup of the county consists of non-Hispanic whites, Black African Americans, Hispanic, and Asians. And you can see the majority of our populations are Caucasian, but we do have a robust, a pretty diverse population here for Iowa. According to the county health rankings, which provides a snapshot of how health is influenced by where we live, learn, work, and play. The county with the lowest rank based on health gets a rank of 1. So when it comes to health outcomes, we are ranked 72 out of 99 counties. The quality of life, we're ranked 73. The health factors, which consist of health behaviors, clinical care, social and economic factors, and physical environment, we are ranked 82. In terms of health behaviors, we're ranked 94, and that was something very important for me to highlight. It's just because of even when conducting our community health needs assessment, we see a predominant need to focus on the health behaviors, which is alcohol and drug use, diet, exercise, sexual activity, and tobacco use. Our social and economic factors were ranked 86, which also lets me know as a health director, we do need to focus on the social determinants of health. And our clinical care, which is ranked at 8, is pretty good, the accessibility of care. And that's because we also have 2 large healthcare systems here, and also SQHC that's very engaged with our community. Next slide, please. Our immigrant and refugee population. So out of our population, 5% of the population are foreign-born. We have immigrant and refugee populations from Europe, Asia, Africa, and the Americas. And we're estimating about over 40 different languages are spoken in Black Hawk County. Next slide, please. So in 2018, the Black Hawk County Health Department was the recipient of an award by the Kresge Foundation, the Emerging Leaders in Public Health. The ELF program is a leadership development initiative which provides local and governmental public health leaders with the knowledge and skills to lead and implement a transformative concept that expands beyond the role of the traditional public health that the community is more aware of. And it is to implement this new transformative and sustainable role for the community. So the Black Hawk County took on the role of a health equity strategist for the community. This is due to the changing demographics of Black Hawk County, the poverty levels in underserved populations, and the importance of bringing awareness of the inequities perpetuated by structural racism in our community. So the co-lead, which is Eileen Daly, the deputy director here at Black Hawk County, and our main goal was to provide the staff and our stakeholders with an understanding of the social determinants of health. We also wanted to make sure that the conversation on racism occurred. We felt that just by talking about the social determinants of health without talking about or addressing racism is more likely to further perpetuate and worsen the existing health disparities. So we wanted a really intentional approach into how do we start off the conversation about, in regards to the social determinants of health, but go even deeper in engaging the community to understand why there are disparities that exist within the different sectors that reflect the social determinants of health. So the intent of our role is to create a community that is resourceful and resilient to transformation and believes in the empowerment and solidarity of its residents to achieve optimal health. And the health department's goal is to function to serve as a resource to partners who are advocating for equity, where we play, work, learn, and worship, advancing unique and culturally sensitive strategies that promote human development and optimal health, and promoting a system of shared community assets to guide the work of local partners to reduce health disparities. Next slide, please. So in the midst of us brainstorming and trying to figure out, okay, we have this new transformative rule, how do we implement it within our agency and within our community? In 2018, and it was around November of 2018, the 24/7 Wall Street published an article that ranked Waterloo and Cedar Falls as the worst city for Black Americans in 2018. This had a very negative emotional impact on our community. For the African American community, it was more of, this is what we've been saying. There's nothing new about this information. This is what we've been communicating for decades, that we have disparities that need to be addressed. We have a lack of resources and opportunities within this community that needs to be addressed. So this was not news to the African American community. We had leaders from the different sectors of the community that some were, to be fair, were also appalled at this information, because for them the Cedar Valley was a great place to live. But as an organization, for us, the health department, we had to think about this is an opportunity for us to use bad news for the greater good. And so it really emphasized the need for us to engage the community in understanding the social determinants of health, to have to be able to collaboratively come together and talk about racism. And so what we did was we invited 50 different stakeholders that resemble the social determinants of health. We consulted with 2 organizations, Engaging Inquiry and Human Impact Partners, and we asked them to facilitate a systems thinking approach to looking at structural inequities. So we asked the community what accounts for the level of equity within our society. So what's working, what's not working, and map it. So here at the health department, we have a robust map of what equity looks like in our community, what the current state of our community, and what are some of the areas we need to zoom in and focus on to leverage our efforts in terms of moving the needle forward. Human Impact Partners came and it gave us an opportunity to talk about racism. And I'll never forget, I had people that spoke to me and said, you know, here I am as an executive in a leadership organization, and this is the first time I'm learning about redlining. So the conversation and this new transformative approach is still ongoing, but however, we had to pause a bit because of COVID-19. So next slide, please. So here in Blackhawk County, I show this picture because it's of a meatpacking industry. And one of the major issues that we faced here in Waterloo was we had an outbreak at a meatpacking plant. And if people are familiar with meatpacking plant, it's predominantly diverse population, underserved populations that work in the meatpacking industry. And so we have of the, next slide, please. So of the 1,916 cases here in Blackhawk County, of that, about 1,031 cases came from this meatpacking outbreak that we had. And of our cases right now, if you look at the data, the majority of the cases, 51% are Caucasian, 18.6% are Asian, and 27% are Black or African American. Earlier, I presented a slide that showed that the numbers of the percentage of populations of these different groups. And this data highlights how COVID-19 is disproportionately impacting the African American community, the Asian community. We have also an African community here, Congolese, Liberians, but it's predominantly impacting individuals individuals that were working, that currently work in meatpacking industries and that have been really impacted by this outbreak. So when the outbreak was occurring, immediately it was important to us for our role as a health equity strategist to take on an extensive approach. And what we did is that we realized that there was a need to close the plant. So we worked with our elected officials across all the different political spectrums and indicated we need one voice. And that voice right now is the health of the community. So in support with the Board of Health, we were able to send out statements to our elected officials at the state level and also to the meatpacking industry, asking the plant to close down, asking for testing of all employees, irregardless of whether they've been tested or not, but to test them. Thirdly, we worked with the community leaders of the respective communities, the African-American pastors, the community leaders of the immigrant and refugee populations, and involve them in what are some of the strategic ways that they can support us with contact tracing, communication to the respective community groups, and also ask what are the resources that are needed. I think for us, one of the key fundamental things that we've learned in this situation here, it's not just about a health department going in and telling people what to do. We need to engage the community. We need to empower the community. We need to elevate them because they are also a resource to us. They are the ones that help us to better understand their community. And I am truly excited about this work and this journey that we are. And so with that, I believe my time is up. And so I would like to introduce Mr. T. Next slide, please. Mr. T. Benicio Gonzales.
Thank you, and good afternoon, everyone. My name is T. Gonzales, and I serve the residents of Louisville, Kentucky as the Director of the Center for Health Equity at the Louisville Metro Department of Public Health and Wellness. A little bit about us: we are an independent academic health department under the leadership of Dr. Sarah Moyer. Our department is organized under three main branches, including health operations, health services, and the Center for Health Equity. Our Center for Health Equity was established in 2006 by Dr. Adewale Troutman. Our vision at the department is a healthy Louisville where everyone in every community thrives, and our mission today is to achieve health equity and improve the health and well-being of all of our Louisville residents and visitors. In Louisville, for us, health equity means that everyone has a fair and just opportunity to be healthy and reach their full human potential. In early March, which was the first phase of our response efforts, Louisville Metro government, through the advisement of our Department of Public Health and Wellness, activated our incident command structure in response to increasing and further community spread of COVID-19 in the Louisville community. For those of you who may not be familiar with the incident command structure, it's a standardized structure used in an emergency that allows agencies, both inside and outside of government, to organize and coordinate response activities. We do this to ensure that the most pressing needs are met and that our resources are used without duplication or waste. Collectively, the people in this structure make up what we call the incident management team. Because critical emergency response plans of actions and strategies are determined within this structure, it provides a significant opportunity for us to infuse equity into our city's response. And I'm sorry, could we advance to the next slide? Thank you. So you're looking here now at what our incident command structure is and our incident management team structure. So what organizational steps did we take to bolster both a public health framing and an equity frame within this incident command structure? First, our Center for Health Equity staff have been utilized as part of the incident management team planning and operations sections. In total, 13 of our Center for Health Equity staff were directly reassigned to work within the incident management team and work on a variety of plans, including providing essential needs to residents and designing the transportation plans for those who might be without transportation, say somebody who's being released from the hospital and who has no other resource to be able to safely get home or to some other shelter that they might be staying in. So our staff have been used in the development of these plans. Additionally, once the incident command structure was stood up, we recognized early on in the process the need to incorporate the city's chief equity officer into this incident management team. And that person has been serving at the same level within our incident command structure as the safety officer. So operating in a similar fashion as we would to ensure that we have safety incorporated in all of our plans and operational pieces, that we also have equity in our plans and operations. Next slide, please. So embedding the Center for Health Equity staff into the ICS has allowed us to rely on their skills that these staff bring to public health practice each day. And these include data analysis, strategic planning, process improvement, community engagement, all of those being built into our emergency response as a city. These staff are uniquely positioned to bring both a health and an equity focus, including an emphasis on addressing systemic and institutional racism and the barriers that that creates to good health and to good strategic planning as well. Prioritizing equity as we would safety in our planning has given us some similar benefits. This means that we've taken steps to ensure that the most people can be kept safe and healthy, that we've taken time to identify gaps that may cause future issues or unnecessary spread of the virus, and that we've established solutions that work for the most people and then create additional options for those who have particular needs. An equity research team was established as part of this incident command structure planning branch. This is the first time for us here in Louisville that we've established such a group to be a part of our ICS and IMT organization for incident management response. This group has been responsible for ensuring that equity is really at the forefront and issues and strategies are mentioned at daily briefings for the entire incident management team to be made aware of. They have completed scans of issues being faced in other cities and done in-depth research on these issues and best practice responses. Our equity research team has also reviewed plans from within the incident command structure and established a brief equity audit to check these plans against. So plans move really, really quickly within this ICS structure. So that equity audit has served as a quick tool to use to identify gaps or areas for improvement for us as a city. Next slide, please. In our efforts from within inside the department, we're strengthening our connections to established community partners to meet the needs of specific and harder to reach communities. Latinx persons account for approximately 4% of the Louisville population, and to date, they account for approximately 15% of our positive cases. La Casita Center here in Louisville has partnered with us during this time to provide an additional layer of resource connection to families facing isolation due to COVID-19. When the department makes a contact with a Latinx person who's facing isolation, they're offered the opportunity to be referred to the staff at La Casita Center to see if there are goods or services that they can provide for them. Currently, one of our Center for Health Equity staff acts as the liaison to La Casita Center to help support delivery of these goods and services. Having a partnership with a trusted, established community organization like La Casita is helping us to maintain connections with residents who have very good reason to lack confidence or trust in government officials. This connection is helping us to better understand how our strategies must address to reach more people in the Louisville community. And I think that we'll carry that lesson forward with us as other incidents will exist in our community in the years to come. Having a staff liaison will also help us to provide continuity as we're in the process now of transitioning to an external vendor who will take over our contact tracing efforts. Next slide, please. As the city's efforts shift towards reopening and recovery, there will be many more opportunities to put an equity framework into practice. The Louisville recovery planning process is called Build Back Better Together, and our Chief Equity Officer has been identified as one of the co-chairs of this effort. Our research equity team is going to be shifting to providing research and recommendations for building equity into the foundation of our economic recovery here locally. This team and our Center for Health Equity staff are committed to providing expertise on the use of equity tools like racial equity impact assessment tools, which can help decision makers understand how budgetary or policy decisions are likely to impact different racial and ethnic groups. These tools can help us to make recommendations to fill gaps that are identified. In Louisville, health equity means that everyone has a fair and just opportunity to be healthy and reach their full human potential. At this time, we're leaning on our history of health equity practice to meet the challenges of this public health emergency and pandemic. As public health practitioners, it really is incumbent upon us to put equity into practice in every way we can during both our emergency and recovery efforts. And now I'd like to invite Dr. Jarvis Chen for their presentation.
Great, thank you very much, T. So I'd like to thank CDC and NACCHO for inviting me to be part of this presentation and to, next slide please, and to share some of the work that our team at the Public Health Disparities Geocoding Project has been doing. Next slide please. Before I get into the slides, I do want to mention I do have some kind of data heavy slides today. I know that we don't have a lot of time to go over every detail, so I'll just be pointing out some specific features of the data that we've been looking at as we go through. The important framing for the work that we've been doing is the vital role of public health surveillance and the fact that in order to understand disparities in COVID-19, we really have to think about who's at risk of being infected and then who's at risk of developing severe disease given that they're infected, as well as who's at risk of dying and who is getting tested and how testing and resources are being distributed in the communities that need them the most. Next slide, please. So really, we can also think about the social inequities by race, ethnicity, but also by socioeconomic position as being related fundamentally to who is able to practice social distancing, who has access to PPE, the living conditions in which people live, the kind of work that people are doing, including those who are working essential jobs and are unable to take time off from that work if they get sick. And also, where are the comorbidities that increase the risk of severe illness and death? Those comorbidities, as we know, have marked racial ethnic disparities. They have a social history to them. And so when we think about how inequity compounds inequity, it becomes very important to think about how these come together to shape the disparities that we see in COVID-19. At the same time, there's a fundamental problem that as we try to get a handle on this epidemic in real time, that often the data have not been available. There's been a lot of attention in the press to how data on race ethnicity are often incomplete, and often the data are not reported as well with age, which makes it impossible to do age adjustment in looking at those patterns. So next slide, please. So even as data on race ethnicity starts to become available, an important thing that we've seen is that socioeconomic data are still not being reported. And in fact, that we know that in a lot of public health databases, the socioeconomic data are just not available. Next slide, please. So the Public Health Disparities Geocoding Project has been around for about 20 years and was in fact created to address this very issue of the missing socioeconomic data in a lot of public health surveillance data sets. And the most important thing in the bold type on the slide is that we established methodologies by which health records can be geocoded by their residential address, and then those residential addresses can be linked to the US Census-derived data on neighborhood socioeconomic characteristics. So this gives us a sense of the neighborhoods in which people live, and also how those neighborhood contextual factors in terms of areas of concentrated poverty or concentrated disadvantage could contribute to disparities in a wide range of health outcomes. So we established this methodology quite some time ago. The papers have been widely circulated and have influenced the way US public health surveillance systems deal with socioeconomic data. And so in the context of this imperfect data available on COVID-19, we realized that this methodology could be used to look at disparities in COVID-19 outcomes. Next slide, please. So this is a slide from our initial report on this, which came out in mid-April, showing at the county level in the United States, disparities by poverty, by percent crowding, and also the percent population of color in terms of the COVID-19 death rate. And at the time, we looked at the COVID-19 death rate per 100,000 persons. Next slide, please. We've since updated these results to look at deaths and other outcomes as of May the 5th. I want to note that on the left-hand side of the plot, we see that this is now COVID-19 deaths per 100,000 person years, which is an epidemiologic way of looking at the rate per unit time. We realized this was important because as the amount of follow-up time increases, we would expect the number of cases to increase as well. And so we wanted to put this on a scale that was robust to the different amount of follow-up time being looked at. What we see consistently across all of the measures that we looked at is that those living in counties that were most disadvantaged by poverty, on the very left-hand side, by crowding, which is the third from the left, and by percent population of color, those in the most disadvantaged counties have the highest rates of COVID-19 deaths. In the second panel, we also looked at this by a measure called the ICE measure, the Index of Concentration at the Extremes. It's a measure of racialized economic segregation that looks at concentrations of people, that measures the extent to which the population in an area is concentrated at either extreme of a social metric. And in our case, we looked at the concentration of poverty among non-white populations versus the concentration of wealth among white populations. And so we see this interesting U-shaped pattern in county mortality that we think is related to the fact that in the communities that were most affected by COVID, even into the beginning of May, that the data are very much influenced by what's happening in New York. And while there's concentration of racialized economic segregation in some of the areas of New York, there's also extreme wealth concentrated, for example, in Manhattan. And so that's influencing the pattern that we see. But in general, we do see that the highest COVID-19 death rates are seen in the most disadvantaged counties. Next slide, please. We also looked at this where data were available by zip code. And so we found data on Illinois COVID-19 confirmed cases that we were able to look at by zip code characteristics. Zip codes are a smaller unit than counties, and so we expected to see sharper gradients, as we can see from the results in this slide. And what we can also see is that by population of color is where we see the most intense gradient on the very right-hand side of the slide, where the rate of confirmed cases per 100,000 person years is 5 times higher in the most disadvantaged zip codes. Next slide, please. And then finally, we also looked at this in New York City, looking at the positive test results. And these are PCR tests, so PCR tests of active viral infection. And what we see are similar gradients to what we saw in the other two analyses, with the strongest gradients being seen by percent population of color, but also by percent crowding. And also to look at these, you can see that the rates are very high, The disparities from top to bottom are a little less intense than in the other two analyses, and that's reflecting the fact that New York was so strongly affected. All of the communities in New York were affected, and not just the most extremely disadvantaged, although the rates were most intense in those groups. Next slide, please. So I just want to mention another analysis that we did that's in Massachusetts, looking at the patterns in excess death. And this is important because COVID-19 death data are sensitive to inconsistencies in testing. So by looking at excess deaths in the year 2000 and comparing it to the comparable time periods in 2015 to 2019, we can get a sense of what the excess deaths are this year that might be attributable to COVID-19. And this includes not just deaths that are confirmed COVID-19 deaths, but also deaths occurring that were not diagnosed as COVID-19 deaths, and also deaths that might have occurred because, for example, people avoided seeking medical care for a heart attack or for a stroke because they were afraid of going to the emergency room. Next slide, please. So looking on the left-hand side and the right-hand side, on the left, we have the weekly age-standardized all-cause mortality rates in 2015 to 2019. And the different colors are representing, in the top row, different categories of poverty, in the bottom row, different categories of crowding. On the right-hand side, we see the same weeks, but for 2020. And it is clear from looking at the graph that there's a surge that occurs in the excess mortality for all groups. It seems to occur beginning in the last week of March and certainly into April. It reaches its peak in the third week of April in Massachusetts, and those surges are most intense in the most disadvantaged areas. So the areas with the highest poverty level and the areas with the highest crowding level. Next slide, please. We also did this analysis by percent population of color and also by our measure of racialized economic segregation. And once again, we see that the surges were most intense in the most disadvantaged zip codes in Massachusetts. Next slide. So I know that we're running out of time. I just wanted to make a few recommendations based on what we've seen, which is that state and local health departments can report data using similar area-based social metrics to the ones we used in our analysis. It would make social inequalities in COVID-19 outcomes visible. And while in our previous work, we had suggested using census tract as a level of analysis, census tracts are much smaller and more homogeneous units of geography. Zip codes are a viable option because it's much easier to get the zip codes, that it doesn't require additional geocoding of the addresses that would be collected in most of the death data or most of the case data. An important thing to keep in mind is that there's often a concern about data disclosure of small area levels if health departments release these data by zip code. And we recommend that the health departments do the work of aggregating these into the categories of area-based social metrics before they report the data, and thereby preventing any concerns about disclosing small numbers. And finally, I just wanted to conclude by saying that it's very important that we be able to get the data on age as well, to be able to do these analyses adjusting for age. Because what we've seen is that when we fail to adjust for age, the socioeconomic gradients and the disparities that we see are often understated because of the very different age distributions by race ethnicity and the different age distributions in areas of different socioeconomic types. So I know I've gone over time. I apologize for that. Thank you very much. And I'll turn things over to Dr. LaViest.
Yes, thank you very much, Dr. Chen. I see that we're running low on time, so I will be as brief as I can so that we can have an opportunity to take a few questions before we wrap up. So decades of policy decisions have created a social infrastructure that's ideal for a highly infectious virus like SARS-CoV-2 to ravage ethnic communities. This is especially the case for ethnic groups that are the most segregated: African Americans, Native Americans, Latinx populations. For example, here in the South, where I live, we have mostly right-to-work states. That is, states where union protections are not available to workers. We also have states that have not expanded Medicaid, so that there are more uninsured people than there otherwise would be. The failure to expand Medicaid has also contributed to many hospital closures, especially in small cities and rural areas. And we know that people who are uninsured are more likely to delay in seeking care. To add to this, we've put prisons and large food processing plants in rural areas to help bring jobs to those communities. But prisons and food processing plants have proven to be ideal places for COVID-19 to spread. So as the outbreak spreads in rural areas and small towns, many of these communities lack the ICU capacity to respond. This is the nightmare scenario that I'm afraid might be coming. I'm currently in the role of co-chair of the Louisiana Governor's Task Force on COVID-19 and health equity. And as part of that task force, the way that we're thinking about our work is that we're thinking not only about getting through this pandemic, but what comes next. So when the country emerges from the current health crisis, we should be focused on identifying policies that can enhance the capacity of our country to respond to epidemics, and also enhance the health of the US population with particular emphasis on addressing health equity and eliminating health disparities, so that we don't come out of the pandemic and go back to our previous state of inequity, but rather come out of the pandemic into a more equitable society. Like other countries with advanced economies, we should guarantee access to quality healthcare for all Americans. This is best done by disentangling healthcare from employment. We should invest in a stronger infrastructure for managing disease outbreaks, regional disaster management centers as government and academic partnerships. In academic public health, there should be more faculty who are jointly appointed, who jointly work with state and local health departments. This would not only enhance the capacity of local health departments, but also greatly improve the quality of teaching and training that we do in academic public health. There should be established protocols for managing health equity related crises, such as the COVID pandemic. In many cases, states have established offices of minority health or health equity. But in some cases, these offices have not been at the forefront of the response to COVID-19. So in my role as chair of the Health Equity COVID Task Force for Louisiana, we note that the director of our Office of Health Equity in Louisiana is a part of our commission. But I've also noted in reaching out to my counterparts across the country that in some other states, the Office of Minority Health or Health Equity is not represented on committees that have been tasked to deal with these the health equity aspects of this crisis. Additionally, I'd be remiss if I didn't point out there should also be a national database for police officers who are fired because of police brutality. That as in previous cases where officers that have been involved in these sorts of activities have been able to move into other jurisdictions and continue to to work as a police officer. And that we should be collecting data on events of this type so that we can monitor as we go forward cases where of police extrajudicial killings of citizens. Further, for public health, academic public health, we need to be teaching the history of race and racism in this country. That should be taught both at the K-12 level as well as in college, but in particular in public health. As the consumers of the work that we do are disproportionately Black and brown people, the producers of public health knowledge tend to disproportionately not be Black and brown people. This situation, I think, is untenable, and that not only do we need to expand the number of Black and brown people getting trained and doing the public health work, but also we need to train everyone who is going to be in public health as a core competency to be knowledgeable about the history of our society and how we came to be where we are. So I'll stop there and we'll have an opportunity, hopefully, to have a few questions and some dialogue.
Thank you to all of our extraordinary presenters. That was fantastic. I am going to ask Lamont if he would assist us with taking questions.
All right, so our first question, thinking forward and thinking about interventions and systematic change, what should local health departments do to flatten the curve in inequities? What should medical providers do, and what should hospitals do?
So I'd like to direct that question to Dr. LaViest first, and if there's any other of our panelists who'd like to speak to that issue, please.
Yeah, well, I think testing is key. I mean, we have not been, we certainly do need a breakthrough in the technology for testing. And as we go forward, opening up these, the economies, you know, being able to monitor or having some sort of surveillance system in place is key. So I'm working on a surveillance system here for New Orleans where we would deploy the symptom checker app to a random sample of residents of the city so that we can monitor on a daily basis whether we're seeing increases in the percentage of people who are reporting that they're having some symptoms. I would like to see some systems like that tried out in other locations as well, because relying on testing hospitalizations, we don't know how long people take before they actually wind up in the hospital. We don't know how many people could have been infected. And if we did something that's a little earlier in the disease process, like looking at early stage symptoms and looking at increases in certain geographic areas, we might be able to deploy resources more rapidly into those communities and get a handle on contact tracing before several days have passed and the person who's been infected has already infected many others in their community.
Any other of our speakers would like to add to that response? Thank you, Dr. LaViest.
Hi, this is Nafissa. I'd like to add to that. But I want to take it a step back. I think that flattening the curve is not just about COVID-19. When you look at the factors, right, when we talk about those underlying conditions, and you hear diabetes, lung disease, heart disease, when I saw those, I was ready, because I knew that it was going to disproportionately impact people of colors, because those chronic diseases are already impacting people of color. So the flattening the curve isn't just with COVID-19. It has to do with beyond just COVID-19. And so I think that's the first message that I think we should communicate if we're talking about equity and getting to the root causes of these issues. The second thing for us here, prior to COVID, we were working on our community health needs assessment. We work with the hospital systems, and one of the things that was very evident is that here in rural Iowa is that you have organizations that are predominantly homogenous. So it's very important also that the healthcare system is intentional in recruiting people of color to assist in providing the quality of care the individuals need, but secondly, also to assist in terms of the effective communication. So here we were getting, when the outbreak at the meatpacking plant occurred, we were getting a lot of calls from community members that didn't understand what the providers were communicating to them. That's the problem in itself. So I think for us is our approach has been, okay, what do we need to do in terms of addressing some of the multicultural barriers that we're seeing? And we worked with Embark, which is a nonprofit organization that offers a robust number of interpreters to provide the language services, because also using just the language line in terms of just doing the interpreter technology, it didn't work. So we needed community members from those interpreters from the community itself, so that they can help the individuals navigate the system.
Thank you. I think that we can take, Lamont, maybe one more question. And I'm really thrilled that I'm seeing a lot of questions come up on our Q&A box, but also congratulatory comments. And so thank you to everyone who has been participating. But if, Lamont, if we could have one more question.
Sure, and some questions have been answered regarding the racial equity impact assessment. If you look in the chat box, that's there. T has provided the link to that. The next one is, how can we be sure to incorporate health equity into contract tracing?
Are any of our presenters involved in contact tracing at this point?
Yes, we are. We are here. This is Nafissa, Blackhawk County. So I think for us internally, again, recognizing that we do need a diverse workforce, one that is reflects the community that we serve. So we're very intentional about the recruitment process here at the health department, because you do need individuals that can help, that understands the community, to be able to do the effective contact tracing that's needed. So those are some of the strategies that we're working on, and also being able to just recruit for that. And working with community leaders, that has been important for us, so that they themselves can understand the process of contact tracing. So we utilize them so that they also can go back and communicate with their community members and understand the reasons why the health department is reaching out to them, and the information that they are requesting. So we work closely with community leaders and representative of those communities.
I'd like to add, this is Jarvis Chen, I'd just like to add the importance of thinking about trust and community trust in contact tracing. It's really vital to the ability of contact tracers to do their work. And so in a context of communities feeling less trust with each other, it's really important to think about that. I've seen some headlines yesterday suggesting that police in Minneapolis were actually using the contact tracing infrastructure to identify people who had been at protests, which is a real violation of trust. And so something that we really have to be alert to. And the other thing that I'd like to say about that is that people's ability to comply with isolation and quarantine is very much related to their perception of their economic situation. And so if we don't institute good policies that, for example, pay for sick leave for people, allow people to take time off of work without being penalized for it, people will not comply with contact tracing if they feel that it will endanger their livelihood. So it's really important that we look at the whole picture and the economic picture as well in thinking about how we proceed together, especially that we are likely to see second, if not third waves of this epidemic. And so we have a real opportunity to notice what we didn't get quite right this time around, and to do better, especially with respect to health equity the next time around.
Thank you. Well, I wish we could go on for, another an hour even. I'm loving the comments, the chat comments that are coming up. I think that the work that our colleagues are doing is right on and right on time. And we look forward to staying in communication with you and continuing to hear how your work is evolving as we continue our work from CDC. So I want to thank our co-sponsors, NACCHO, our speakers again. Want to applaud Lamont Scales and Laura Ross and the work of the Community Intervention and At-Risk Task Force for their leadership in pulling us all together today. And I just want to say to everyone, be well, take care of yourself, and we look forward to staying in touch with you. Thank you.